Okay, we're now live. It's always a matter of waiting for Facebook to tell me we're live. Hi, everybody. Hope everybody's doing well. It's Thursday, September 25th. Whole lot is going on. Everybody, it's now officially fall. I think the 21st was the transition from summer to fall, but it's been pretty good weather. I mean, here we've been having 70-ish degrees, and we haven't had any storms yet, though, usually the problem is Florida or Louisiana, North Carolina, where they get the hurricanes, because we're in the middle of hurricane season. I don't want to jinx it, but there hasn't been like last year where this seems to be the hurricane of the day, so that's kind of good. Today I'm speaking about splenic masses, so let me get started on that right off. When you think about the spleen, there's always a challenge. The spleen is on every single scan. It's on every abdominal scan, the entire spleen, and probably half the spleen or a quarter of the spleen is present on every chest CT. Splenic pathology is a range of things from benign lesions, think cholangiomas, hamartomas, cysts, to malignancies, think metastasis, lymphoma, sarcoma. So how do you deal with lesions? Now, one of the challenges with splenic lesions is in terms of protocols, we usually do a single phase study, sometimes dual phase, but there's not been a lot done on the spleen, or we've done a lot, but we've not been able to come up with any great ways typically of separating some of the pathologies, though I think we do a very good job. I think at the end of the day, the far majority of incidental splenic lesions are benign, and so most of them, if you find nothing else, are left alone. If they're incidental findings, no one's doing biopsies typically. Biopsies can be somewhat dangerous, and people don't like biopsying the spleen. So what do we look at? What do we think about? And I'm giving a talk, and I'm going to have the talk on CTisus hopefully in a few months. I'm going to record it hopefully this weekend, but then it takes a few months till we catch up. What do you think about hemangioma? Hemangiomas can look identical to hepatic hemangiomas, low density, peripheral enhancement filling in. They can be cystic, low density, with coarse calcifications. They can be low density with really no enhancement. They can be single or they can be multiple. Klippel-Trenaunay-Weber syndrome, you have multiple splenic hemangiomas, but you can have multiple splenic hemangiomas, though not as many, just as a routine finding. We talk about hamartomas. These are large benign lesions. I usually can diagnose them because they protrude off the spleen. They are well defined, 3 to 6 centimeters. They're homogeneous when they enhance on early and late phase imaging. They're benign. We talk about a whole bunch of things that are really hard to diagnose. Inflammatory pseudotumor of the spleen looks like malignancy. It's benign, but the only way you make it benign is you get pathology, you do a splenectomy. We talk about sand tumors. We talk about angiomatosis that are benign but can be difficult to diagnose. We talk about inflammatory disease like sarcoid. Sarcoid can have multiple or single lesions in the spleen and liver. We talk about abscesses. You can have a splenic abscess. Often it's related to things like diverticulitis or something like that, appendicitis perhaps. Or you can have splenic abscesses when they're multiple, small, like candidiasis, and it's typically related to immunosuppressed patients. And then you also see the lesions both in the liver, the spleen, and often in the kidneys. So abscesses can occur. Again, clinical history, the patient's sick. And so when you see splenic lesions in a patient who's febrile, you got to be thinking about abscess. You can think about tumors, right? Lymphoma is the one you think about. You may only see tumor in a large spleen or infiltration. You may have the equivalent of myelofibrosis or just diffuse infiltration in a very large spleen. Or you may have the spleen involved, then liver and kidneys might be involved. You may see adenopathy. So a very important thing is when you're looking at splenic lesions and they're incidental is look around. Often the findings in other places will make your life a whole lot easier. So that part's really a good way of thinking about it. You could have metastasis. Melanoma is probably the classic one. But again, when you have melanoma at the spleen, you'll have it to liver, you'll have nodes, maybe small bowel. We have the spleen invaded. You can have gastric tumors like a GIST tumor invading the spleen. Most commonly, you talk about tail of pancreas, pancreatic adenocarcinoma that just grows into the spleen. Since I mentioned pancreas, you can have pseudocysts in the spleen. It's a sequela of pancreatitis where fluid tracks along the splenic artery and vein and through the capsule and can go into the spleen. Patients with splenic pseudocysts, as you would refer to them, are more prone to spontaneous splenic ruptures or mild trauma giving splenic rupture. We talk about the vessels of a spleen. Splenic artery aneurysm is the thing you typically think about. Splenic artery aneurysm, we worry when it's more than 2 centimeters. There's a question about embolization or resection when they start getting larger than that. We talk about splenic vein thrombosis, but typically they can be associated with anticoagulable state, but typically is associated with things like pancreatitis or tumor extension. So that's something else to think about. We talk about strange primary tumors of the spleen. Very, very vascular tumor, maybe with vein calcifications. Spleen is large. You talk about a primary angiosarcoma of the spleen. You can have angiosarcomas of the liver, also involving the spleen. I mentioned Mets, I mentioned lymphoma, I mentioned extension of tumor like by pancreas or gastric. I mentioned the benign lesions. I mentioned the inflammatory infectious lesions. We've seen unusual infections besides the candidiasis, which again, clinical history helps immunosuppressed. We've seen brucellosis, for example. Strange things can involve the spleen. You also have massive splenomegaly, things like mononucleosis, things like myelofibrosis, extramedullary hematopoiesis. Patients with very large spleens are more apt to spontaneous splenic rupture with minor trauma or even without trauma. So that's kind of a way to think about splenic lesions. It can be challenging. Again, 99% of incidental splenic lesions are benign. There's a few good articles. I think that we'll put some of them up, the references. A good article in Radiographics last year. And again, I'm giving a talk. It'll be a 3 or 4-parter. So everything you want to know about splenic lesions will be in that talk. So with that, I'm going to stop there, go back to work, and I hope everybody has a great day.